if anybody has any questions, please come up to the microphone and identify yourself. Everybody's going up to the mic. Oh, we have a question at microphone 2.
Okay, Terry Plassey, New York. The question, I guess, for all the panel members. You talked about different, I guess, risk factors or factors to assess when deciding on, say, intermittent versus continuous androgen depression. You didn't talk about age. Is there any information, are there any data which suggests that starting a younger patient versus an older patient is more at risk of either, well, obviously patients at risk longer if he or she, if he's younger, but is there a higher risk in terms of sarcopenia or osteopenia, for example, or cardiovascular problems with androgen at older versus is at older age, when the patient's already further along the line in terms of the potential problems?
Well, yeah, of course. I mean, because I already told you that men get osteoporosis anyway, forget ADT. I mean, it's an age-related phenomenon. The same thing is true with cardiovascular disease. So, yeah, of course. But on the other hand, sometimes, you know, older men might have more slow-moving disease. I mean, they may or may not. I mean, so I would decide about whether or not to use ADT based on the pace of their disease, not based on their age or their other risk factors necessarily. I mean, if I can avoid it, I will. Well, in general, I would say unless there's other factors, I will start the ADT. And this is true whether it's, well, this, for guys with non-metastatic disease, I will start ADT and I will, you know, follow them for 8 or 9 months and see how they're doing. And if they're having symptoms, which I would say most of them do, even if they're older, I will offer them intermittent therapy. There's a few guys who I don't understand why. They don't have that many side effects of ADT. And in that case, I'll give them the option if they want to stay on continuous or if they want to cycle off. I am a student of intermittent therapy, so I tend to lean towards that because I do think there are various you know, things that are mitigated, such as the bone loss. And, you know, we really don't have a good handle on the cognition and some of the other things we didn't talk about. So my own bias is to intermittent therapy in patients with biochemical relapse.
Yeah, I would concur with that as well. And it doesn't matter the age of the patient. I look at the disease factors, Gleason score, the rate of PSA rise, and the risk of prostate cancer death, and whether to initiate the androgen deprivation therapy. But I'm looking for a reason to do intermittent therapy in those in all patients. Why don't we move to another question at microphone 3?
O'Rourke from Greenville, South Carolina. A question about using the fracs. I do use it, but I have not been checking secondary osteoporosis just because they're on ADT. I thought there needed to be bone criteria or fracture criteria to call it secondary osteoporosis.
Well, no, I don't think so. I think that the advice is that they should be considered to have secondary osteoporosis if they're being treated with ADT. And that's something that Matthew Smith lectures about when he discusses use of the FRAX tool. So I consider him one of the major experts. So I would go with that.
Microphone 2.
Kucharov, Germany. Are there any differences in respect to sarcopenia between the different drugs? We are approaching a time of first line, second line, third line endocrine therapy. So all the men will lose their muscles. They get 2 years, 3 years, 4 years of therapy. Are there any difference?
You mean between the agonists and the antagonists, or enzalutamide, abiraterone?
what kind of advice would you give your patient? Start chemotherapy or give second-line abiraterone, for instance, if he has a severe sarcopenia?
Well, in those patients, well, for the castration-resistant prostate cancer patient that's progressing, I think the risk of death is extremely high. And so I think it'll be whatever is best serviced for treating his disease and helping maintain survival. I think in terms of looking at the patient with that's castration sensitive and we're trying to deal with the sarcopenia, I think there's good evidence that an exercise program using resistance exercise can help combat that. So it is an important problem, and we should encourage our patients to exercise. I'm not sure about whether there's any data on intermittent therapy, whether that can improve muscle mass, but I would suspect that, like the osteoporosis data or the bone loss data that Tia has shown, that there would probably be benefits there, and it's deserving of study.
Yeah, actually, I mean, I can tell you anecdotally that guys who, already exercise with resistance exercises do tell me that their strength improves during the off-treatment intervals. They know because they know how many reps they do. But there's also, there are some very interesting agents that are going to be in clinical trials that may be good for sarcopenia, for building, muscle fibers, and it may be that in time we might get to see if some of these are effective in preventing the sarcopenia from ADT.
We'll move to microphone 1.
Chevron North Shore, excellent and very useful talks. Comment and a question. Comment is perhaps from what you're saying, when one wants to consider intermittent versus continuous therapy in a man who has known underlying cardiovascular disease, you may want to consider intermittent therapy with an antagonist as opposed to the other. And I guess my question is if you could speculate on the possibility that a 5-alpha reductase inhibitor might enhance the effectiveness of intermittent therapy given during the regrowth phase.
In terms of the antagonist comment, and that's intriguing, but I would agree with Tia that I'd like to see some prospective data to ensure that it's a real effect rather than just a retrospective discovery by chance. In terms of 5-alpha reductase, that's certainly been looked at in various case reports and case series that I've seen in terms of both trying to use triple therapy, LHRH plus non-steroidal anti-androgen plus 5-alpha reductase at that, but also on the off-treatment phase to try to slow down the rate of rise of PSA and perhaps lengthen out that duration of off-treatment. Certainly interesting, but difficult to prove that it has efficacy.
Now, isn't there a Canadian trial, Dr. Chi, that actually looked at that very question? I don't think we know any results yet, and as I recall, it was mainly looking at the first cycle of therapy, and patients were randomized to get a 5-alpha reductase inhibitor or not. But I think we don't know the results, but it's certainly a good question.
Great. Microphone 2.
I've actually, there are 2 issues. Number 1 pertains to the stem cell, the cancer stem cell involvement in the environment of intermittent versus continuous therapy. And as I understand it, the jury is still out because we really don't know if intermittent therapy versus continuous therapy selects the more resistant clones. Do you have any idea about that? Because the data that you showed, of course, are intriguing, but as you pointed out, there actually in the clinical setting there doesn't seem to be an impact on the outcome. The second issue was that most of the data present overall survival data that are not censored for disease-specific survival. And I mean, there are really 2 issues. This is an elderly population where you have patients with more or less comorbidity, And I think that's one issue that should be addressed separately from the disease-specific issue, which is the death of cancer. So, I mean, when we look at overall survival, of course, this is a confounding population. And so I'd rather would like to see the data analyzed specifically towards risk on one hand and disease-specific risk rather than confounding both in an overall survival curve.
For the Canadian-led study on the M0, so patients without metastases, rising PSA, I didn't show all the data, but they did do that kind of analysis with the survival curves looking at prostate cancer-specific mortality versus death from other causes. And there was that sort of balance that the patients on intermittent therapy had a slightly high, this is all statistically not significant, we have to remember that, but they did have a slightly higher risk of death from prostate cancer, but a lower risk of death from other causes. And it was kind of alluding back to the risk of hormone therapy in general at increasing risk of death from other causes, namely cardiovascular or other things. While this was the opposite in the continuous androgen deprivation therapy arm. So I would agree with you when we're trying to decide whether to start hormone therapy in a man, we really have to think about the competing causes of death for those that have no metastases. I think I haven't seen that data for the metastatic trial. Maybe Tia knows more about that, but I would suspect most of these guys are dying from prostate cancer. Tia, do you want to comment?
Thank you.
Microphone 4.
It's more a curiosity than a practical question. Looking for the correlation between testosterone recovery and PSA recurrence or disease recurrence. A couple of specific issues. Can one predict how long is the person's going to be hypogonadal once they've stopped the LHRH antagonist? Remember, do old people take a lot longer to come back than younger folks? And then when they do come back with a PSA recurrence or some evidence of disease, what kind of testosterone levels does one see?
Go ahead. Do you have a...
Well, I will just say with the older, younger thing, there is certainly retrospective data looking at the time course of testosterone recovery. And in some studies, it says, if you're on a short course of ADT, that you'll recover very quickly, meaning within 3 to 6 months. But if you're on a longer course of ADT, as the course gets longer, it takes longer for the testosterone to recover. The other thing that's come up a lot is age. So it hasn't come up consistently on every single study, but if you look at some of the retrospective studies, they'll say that age is a factor significantly associated with time to testosterone recovery. If you look at the early radiation trials where the median age of men was 73, when 73-year-old men got 6 months of hormones, the median time to testosterone recovery was 2 years. So the short course really kind of turned into long course for the older cohort of men, whereas we know if you take an average 65 or 60-year-old man, it's going to be probably 3 to 6 months by the time he rebounds.
Yeah, the one follow-up I would have to that is that there's testosterone recovery, and there's when the patient starts reporting feeling better. They're not necessarily tightly linked. So a patient may actually start feeling better as the T level bumps over the castrate range, even in the 100 range. And so technically their T isn't recovered yet. That's the first thing I was going to say. The second thing I was going to say is that we have seen with repeated cycles of intermittent therapy, and this is usually over years, that the T recovery is not as good as it used to be at the outset.
Does the PSA come back before they are no longer castrate? In other words, correlate the PSA with the testosterone. Still have testosterones of less than 20, but disease growing.
So in my experience, yeah, you do see that, especially just as the PSA or the testosterone starts to recover, generally the PSA starts to go up, but it's highly variable. You have some men where the testosterone recovers and it takes a while for the PSA to start increasing, and the opposite. But in general, as the time course goes on, your intervals between treatments start to decrease, and then eventually you see the castration resistance develops. Excellent. If there's no more questions, I'm going to close this session. I'd like to thank my speakers and my fellow speakers, and I'd like to thank all of you for sticking it out to the end. Thank you very much.